um, when you think about architecture, you usually think about, well, the foundational elements of a house.
Right. Like the concrete, the framing.
Exactly.
Yeah.
And if that foundation shifts or, settles over a couple of decades, you see the effects everywhere. The doors suddenly start to stick in their frames. The floorboards might warp.
The roof line sags.
Yeah, the roof line sags. And you can't just slap a fresh coat of paint on the drywall and pretend the house is fine.
No, it doesn't work that way.
Right. You have to actually go down into the basement and repair the underlying load-bearing framework.
Yeah, because if you ignore those structural mechanics, the cosmetic fixes are just, they're entirely useless. The environment will literally just tear them down again.
Which brings us to today's deep dive. Welcome, everyone. We are looking at a piece of human architecture that goes through these massive structural shifts over a lifetime, but it really rarely gets analyzed from that reconstructive, load-bearing perspective.
We are talking about the labia majora.
Yes, we are. And we've pulled together this really fascinating stack of medical literature for you today. We're looking at the Isolane study, the Duzeryl injection protocol.
Which is incredibly detailed, by the way.
Very detailed.
Yeah.
And also these advanced anatomical mapping papers that focus on this thing called the vulvar anatomical vector technique.
Right.
And what stands out immediately across all these clinical texts is that this procedure, labia majora augmentation, it is rarely just a cosmetic touch-up.
No, not at all. The literature frames this almost entirely around functional restoration.
Right.
Because when a patient experiences significant volume loss in this area, and that could be due to just natural aging or, the severe estrogen depletion during menopause.
Or even massive weight loss, right?
Exactly. Massive weight loss is a big one. They're losing a critical protective cushion. And without that biological padding, patients frequently suffer from, severe chafing.
Oh, wow.
Yeah, persistent friction, really intense mechanical irritation during just basic daily activities.
Like just walking or exercising?
Exactly, because the internal structures, like the labia minora and the vestibule, they absolutely rely on that outer cushion to act as a physical barrier.
So when the cushion deflates, those internal mechanics are just exposed to environmental stress they were literally never meant to handle.
Yes. So before a practitioner even considers, picking up an instrument, they have to completely understand the topography of this canvas.
Okay, so let's unpack that tissue landscape.
Yeah.
Because the sources, they repeatedly divide the target tissue into two very distinct layers, right?
Yeah.
You've got the superficial subcutaneous tissue, the SST,
Right.
and then the deep fat pad underneath it.
And treating those two layers as distinct functional zones is basically the difference between a successful restoration and a complete clinical disaster.
Wait, really? A disaster?
Oh, absolutely. So the labia majora are essentially two prominent anatomical folds flanking the vulva. They're packed with sebaceous glands, hair follicles.
Right, the skin surface.
Yeah, but beneath the dermis, the fat isn't just this homogeneous, unorganized blob.
Yep.
It's highly compartmentalized. The SST, that superficial layer, is incredibly thin. It sits right under the skin, and it completely lacks the robust connective tissue network you'd need to camouflage any added volume.
Okay, that makes me think of like a decorative couch cushion.
Okay, I like where this is going.
Like if the cushion is flat and deflated,
Right.
and you just aggressively cram handfuls of synthetic stuffing right under that thin silk cover, you're going to get a lumpy, uneven mess.
Totally.
Because the thin fabric can't hide the irregularities of the stuffing.
Exactly. And the clinical reality is actually even less forgiving than your cushion analogy.
Oh, great.
Because the superficial skin layer of the labia is just uniquely delicate. If a practitioner injects hyaluronic acid filler into that SST layer, aiming to build volume, the product will inevitably clump.
Oh, yikes.
Yeah, you get visible granulomas, really severe surface irregularities, and basically a total loss of natural elasticity.
So they don't inject there at all?
They might do a tiny superficial sweep just to treat fine skin wrinkling, but never for volume.
Got it.
The actual structural foundation, the place that is biologically designed to hold bulk, is the deep fat pad.
And that deep pad is sitting right on top of a layer of connective tissue, right? Callus fascia.
Yes, callus fascia.
So if we're sticking to the architecture concept, I assume callus fascia basically acts as the structural floorboards of this anatomical room.
That's a really solid way to visualize it, actually. It's a tough, fibrous, membranous layer. It bounds the superficial perineal pouch.
Okay.
So the deep fat pad is sandwiched perfectly between those rigid floorboards below and that delicate superficial layer above.
So it's locked in.
Exactly. And when you deposit the hyaluronic acid filler into that specific deep space, you achieve what the clinical texts refer to as coaptation.
Coaptation, meaning like you are volumizing the labia majora enough that the medial edges physically meet in the middle again.
Yes, they come together and effectively seal off and protect that sensitive internal mucosa we talked about earlier.
Okay, so the practitioner goes deep for structural volume and avoids the superficial layer to prevent the lumps.
Right.
But getting into that deep fat pad, I mean, reading these sources, it sounds like navigating a total minefield.
How about it is?
Because the arterial mapping in these studies is just intense.
Yeah, the vulvar region is one of the most highly vascularized zones in the entire human body.
Wow.
You're dealing with a massive convergence of blood flow. You've got the anterior labial arteries, which branch off the external pudendal artery to supply the front, and then the posterior labial arteries, branching from the internal pudendal artery to supply the back.
And these aren't just like minor, insignificant little capillaries, right?
No, not at all.
These are major supply lines, keeping the entire pelvic floor network alive and oxygenated.
They are high-flow arterial highways. So the risk of intravascular injection here, meaning you accidentally push a thick, viscous hyaluronic acid gel directly into one of these arteries, carries catastrophic consequences. We're talking about ischemia.
Tissue death.
Exactly. The downstream blood supply is instantly blocked, which can rapidly progress to severe tissue necrosis.
Okay, so this brings up a detail in the methodology that I really have to push back on.
Okay, let's hear it.
If this entire region is an absolute minefield of major arteries, why do the Isolane and Desirial protocols so emphatically forbid the use of sharp needles?
Ah, right.
I mean, wouldn't a fine, sharp needle give a practitioner the exact, like, millimeter level precision they need to carefully weave between those vascular structures?
You know, it seems logical at first glance.
Right.
But a sharp needle is actually the primary hazard in a highly vascularized zone like this.
Wait, really? Why?
Think about the physical properties of a traditional medical needle. The bevel is engineered to slice through biological tissue with minimal resistance.
Right.
So if a sharp tip encounters an arterial wall while it's navigating through that dense fat pad, it won't give the practitioner any tactile warning whatsoever.
Oh, it just goes right through.
Exactly. It will simply pierce right through the vessel wall, and suddenly the practitioner is intra-arterial.
So they're laying down structural filler directly into the bloodstream, without even realizing they've breached a vessel.
That is exactly the nightmare scenario these protocols are designed to avoid.
Wow. Okay, that makes sense.
Yeah, and this is why a blunt cannula, and they specifically mandate ranging from 18 gauge to 25 gauge, is strictly non-negotiable for the deep fat pad.
Because it's blunt.
Right. A cannula features a rounded, blunt tip, and the extrusion port where the filler actually exits is located on the side of the shaft, not at the point.
So it's kind of like walking through a dense, overgrown forest in the dark.
Okay.
A sharp needle is basically a machete, just blindly hacking through whatever is in front of it, including the critical vines and branches you desperately want to preserve.
Yes.
But the cannula is like using your hands to gently push the branches out of your way as you navigate the path.
The tactile feedback is the key differentiator there. Because the tip is blunt, it requires more deliberate physical force from the practitioner to advance it through the fibrous septa of that fat pad.
They can feel what they're hitting.
Exactly. When that rounded edge inevitably encounters a blood vessel or a nerve bundle, it just doesn't possess the cutting power to pierce it. It physically pushes that resilient vascular tube aside and just glides safely through the softer subcutaneous fat.
Okay, so the blunt cannula prevents you from slicing the plumbing once you are already inside the walls.
Right.
But you still have the problem of getting inside the house in the first place.
Yeah.
You can't just push a blunt object through intact, healthy skin. You have to create an entry point.
You need a safe doorway.
Right.
And because of that dense vascular web concentrated toward the midline of the vulva, finding that doorway means you have to adhere to really rigid anatomical landmarks.
Can't just guess.
No, you absolutely cannot just guess based on visual inspection.
And the texts map out a few of these doorways, but they use incredibly specific coordinates, like let's analyze the upper entry points in the latero-pubic area.
Oh, okay.
The clinical guideline states the entry must be exactly 2 to 3 finger breadths lateral to the vertical center line, positioned between the pubis and the posterior commissure.
Yes.
So if I'm looking at this structurally, I have to assume moving outside that specific window is where the danger lies. But why 2 to 3 finger breadths? What is hiding at like 1 finger breadth or 4?
Well, if you move too far medial, say just 1 finger breadth from the center line, you are stepping directly into the path of the internal pudendal branches.
The ones that supply the clitoral and vestibular networks.
Exactly. You are putting the cannula right in the high flow danger zone.
Yikes.
But conversely, if you move 4 finger breadths out, you're leaving the labial boundary entirely and hitting the genitocrural fold.
The crease of the thigh.
Right. And there, the tissue architecture completely changes, and you can no longer properly access the deep fat pad at the correct angle.
Ah, okay. So that 2 to 3 finger breadth window is the anatomical sweet spot. It is lateral enough to bypass those major central highways, but medial enough to remain aligned with the longitudinal axis of the labia majora.
And that alignment dictates the trajectory, which is crucial. In fact, the Desirial protocol establishes a broad foundational rule of thumb for this. Entry points must be lateral and low.
Lateral and low.
Right, and you see this principle applied to the lower entry points as well. Those are situated exactly 2 centimeters lateral to the labia minora in the posterior commissure region.
Okay, the posterior commissure being that anatomical band where the labia minora meet at the bottom edge.
Yes.
So by creating the entry puncture 2 centimeters completely outside that boundary, the practitioner is basically establishing a safe base camp far away from the central vessels.
Exactly. And from that safe lateral base camp, typically with the patient in the lithotomy position, legs elevated and supported, the cannula is inserted upward and diagonally.
Let's track that vector for a second.
Good.
If the practitioner starts low on the outer edge and angles the cannula diagonally upward toward that genitocrural furrow, they are essentially running the instrument parallel to the dangerous central vessels, right?
Right.
Rather than ever crossing over them.
Utilizing a parallel trajectory is actually the entire driving philosophy behind that vulvar anatomical vector technique paper we reviewed.
Oh, right. The VA vectors.
Yeah, they meticulously map out different vectors to treat highly specific tissue deficiencies. Take the VA4 vector, for instance.
That's the VA4.
That one specifically targets the upper zone between the labia majora and the mons pubis, usually to improve overall tissue tone.
And for that specific upper zone, the required puncture is mapped at roughly 2 centimeters above the anterior labial commissure, right?
Right, and by entering at that precise upper landmark and fanning the cannula downward along that VA4 vector, the practitioner remains within a designated pre-mapped safe zone.
A safe zone that completely avoids the external pudendal artery branches that are crossing higher up near the mons.
Exactly, it's brilliant.
It is pure architectural engineering. I mean, the practitioner analyzes the load-bearing walls, maps the internal plumbing, and only drills the pilot hole exactly where they mathematically know there isn't a pipe.
That's exactly what it is. And because these blunt cannulas are quite long, they really only need that single puncture to reach the entire structural column of the labia.
Which I'd imagine significantly minimizes trauma to the superficial skin.
Oh, absolutely. It reduces the risk of post-operative infection and limits the inflammatory response overall.
Okay, so the cannula has successfully breached the outer doorway. It has navigated past the delicate superficial layers, bypassed the vascular web, and is now seated deep inside the fat pad, right above that fibrous tunic of callus fascia.
Right, where we want it.
The final phase is actually distributing the hyaluronic acid filler. But the fluid mechanics of this phase are highly regulated in the text, right?
Very much so.
Like, the practitioner cannot simply depress the plunger and push a big bolus of gel into the tissue. The standard protocol across all the sources is linear retrotracing, utilizing a fan-shaped distribution pattern.
Yes, the retrograde fanning technique.
Meaning, they are laying down the filler continuously as they slowly withdraw the cannula rather than as they push it forward.
Correct. Usually about 1 to 3 Belleville per side.
But wait, if they are already confirmed to be in the safe deep plane, why is it considered so dangerous to inject while advancing the instrument.
Because even a blunt cannula creates a localized pressure wave in the tissue as it moves forward.
Oh,
So if a practitioner injects while pushing, they are driving a dense, viscous gel blindly into the unnavigated tissue ahead of them.
right.
And if the blunt tip happens to be compressing a hidden vessel against a fibrous band, even if it hasn't pierced it, the immense pressure of that filler bolus exiting the tip could theoretically rupture the vessel wall.
Oh, wow.
Or it could externally occlude it just from the pressure, causing the exact ischemia they were trying to avoid in the first place.
So you're essentially bulldozing the gel forward into unknown territory.
Exactly.
You know, the retrotracing technique reminds me of watering a large patch of dry lawn with a garden hose.
Okay.
You wouldn't just march to the dead center of the grass, point the nozzle straight down, and turn the water on full blast?
No, you'd instantly flood that one spot. You'd create this localized mud pit while the entire rest of the lawn remains completely dry.
Right. So to get an even distribution, you stand at the outer edge, you sweep the hose across the surface of the grass, and you lay down an even, controlled spray as you slowly pull your arm back towards your body.
That's exactly it.
And then you change the angle slightly and sweep back again, overlapping the previous track.
That overlapping retrograde fanning motion, pivoting from that single entry point, is exactly how practitioners prevent localized pooling of the hyaluronic acid.
So they're just painting the volume on.
Yeah, the practitioner is laying down these fine, contiguous threads of filler in a space the cannula has already safely cleared. You are essentially leaving a structural matrix behind in a tunnel you know for a fact is empty and safe.
And because it's deposited over multiple overlapping angles, it creates that broad, even volume required for the coaptation, bringing those labial folds back together to seal off the vestibule.
Exactly. But laying down the tracks isn't actually the final step.
Oh, right. The sources emphasize immediate post-injection manipulation.
The physical molding of the tissue.
Yeah.
Because the hyaluronic acid gel is deposited in those smooth, parallel tracks within the deep fat rather than one chaotic lump, the tissue remains highly malleable immediately after the procedure.
So the practitioner physically massages and shapes the labia.
They do. They mold it to ensure the filler integrates seamlessly with the patient's natural fat lobules.
They're literally sculpting the tissue from the inside out, making sure the artificial cushion mimics the biological cushion perfectly.
Yes. The gentle molding ensures there are no sharp demarcations, which allows the product to settle smoothly against callus fascia and support that delicate SST layer above it without distorting the skin.
It's just an incredible process. But there is a biological reality to this specific anatomical area that aggressively challenges the longevity of all this precise sculpting.
The degradation timeline.
Right. Because the clinical literature notes that hyaluronic acid fillers in the labia majora generally only last somewhere between 9 to 12 months.
Which is a remarkably fast degradation timeline when you compare it to the biomechanics of other regions, like the midface, for example, where fillers can sometimes persist for years, right? But think about what we just spent this entire analysis mapping an incredibly intense high-pressure vascular network.
You have constant hemodynamic heat from all that concentrated blood flow, plus the massive daily mechanical friction from just walking or sitting.
Right.
And significant tissue forces that the labia majora are literally designed to absorb.
The environment is incredibly hostile to a static structural gel. The ambient heat and that relentless mechanical friction, they seemingly accelerate the enzymatic breakdown of those cross-linked polymers at a much higher rate than, say, a filler sitting quietly, undisturbed along a cheekbone.
It's a hyperactive microenvironment that is actively trying to dismantle the artificial architecture for the exact moment it's injected.
It really is. But, you know, that intense microenvironment raises an even more compelling biomechanical question for you to think about regarding the long-term impact of this procedure.
Wow, what's that?
Well, we know from dermatological studies that the physical presence of hyaluronic acid filler and the mild but persistent mechanical stretching it exerts on the surrounding tissue can actually stimulate fibroblasts.
The biological cells responsible for producing structural proteins, primarily collagen.
Precisely. So amidst all this friction and rapid filler breakdown, could the ongoing mechanical tension placed on that deep fat pad actually be triggering a profound localized collagen response?
Wait, so are we looking at a biomechanical process where the temporary hyaluronic acid scaffolding is essentially forcing the body to lay down its own permanent endogenous reinforcements over time?
It's highly possible.
That is a fascinating concept. The idea that by the time the artificial filler fully degrades, the biological architecture has already been permanently upgraded by the body's own response to the intrusion.
Right, it transforms from a temporary cosmetic patch into a permanent biological reinforcement of the foundation.
It really does all come right back to the architecture. If you rebuild the load-bearing elements correctly and subject them to the right kind of stress, the whole structure learns how to carry the weight again on its own.
Exactly.
Well, thank you for joining us on this deep dive. Keep analyzing the incredible mechanics of the human body, and we will catch you next time.